Dr. Doherty again. I'm going to take my mask off here because I'm well away from anyone. Welcome to our 6th update on COVID-19. My partner, Dr. Rodrigue, has done an extremely thorough job and put innumerable hours into these updates. Dan, I want to really thank you for all the work that you've committed to this. Today we're going to discuss a number of aspects, including an update on the epidemiology, some on therapeutics, and also some on the complex immunology of cytokine storm. This update will be eligible for continuing medical education credits. You'll have to fill out a questionnaire, and that's being arranged. At this point, we're thinking that we will probably need to do another update in around 3 or 4 weeks. We're probably not going to be doing them as often as things have settled down, and unless something emerges as we open up the economy. But thank you again, Dan. Here's Dan.
To start off, let's give a thank you to everybody that's been through the last 3 or 4 months, especially our family, all the healthcare workers, the nurses, the doctors, the RT, the environmental workers, everybody, our administrators, public health workers, public servants, and the people of Kentucky that everybody has had to come together to deal with this new pandemic. So let's give a shout out to all those people who behind the scenes, a lot of them work countless hours and just don't get enough credit. I would include all my own family and then all my coworkers in my practice. A lot of people working at every hospital. Not everybody gets notoriety. Not everybody gets their name in a newspaper or in some kind of television thing. But man, they're working really hard, and they all deserve the credit as well. None of this could be done without cooperation from many people. So today's update objectives are listed there. I have nothing to disclose financially. So let's just dive into it. In terms of the epidemiology, it continues to increase. Cases globally are over 4 million to date, 278,000 deaths. You have some new countries increasing in terms of their rates, including Russia, which is, in terms of the number of cases, is behind the United States, Spain, UK, and India. Case fatality rates will differ depending upon what series you read. Some will be higher, some will be lower. As we gather all the information, the case fatality rate will likely be 1% or less. We know that risk factors are still holding true in every country, and that is those age over 60 with comorbidities in terms of obesity, hypertension, COPD, diabetes are at increased risk, and there's still a 5-day incubation period of 2 to 14 days. Over the last month or so, there's been increasing data showing racial issues in terms of increasing disease and disease burden in African Americans and also in males. All the reasons behind that are not known yet, and that's being discussed and researched. Still a bat origin in terms of genetic sequence, but as you've read over the past couple of weeks, the entire story behind whether or not this began in a lab or this began at the wet market, really we don't focus on those types of things. We're focusing that we know this is a new virus. It has genetic similarities to the original SARS virus, and it has a bat origin. Going forward from there is still unclear. If you look at WHO's map, the darker areas, this is over the past 7 days, the darker areas of confirmed cases show that the United States and Russia and South America are still cranking it out. Africa tends to lag behind in terms of reporting, so that will continue to increase as time goes on, and plenty of data showing that it's difficult, especially in resource-limited countries. The transmission routes have remained steady in terms of what is thought to be important with the new information coming in, droplet contact and less likely aerosol being important, except for during aerosol generating procedures. Still no good evidence for vertical transmission in pregnancy, although you will read different articles hinting that that might still be a possibility, but the wealth of evidence does not show that to be significant. You can find SARS-CoV-2 in multiple specimens, with BAL still being the highest area to obtain a positive PCR test, and there are still data coming out that are being validated as time goes on. Hopefully, with more information, we will get more data on whether there's value in doing saliva testing or some other less invasive testing going forward. We know that SARS-CoV-2 is also found on numerous surfaces. If you go into patients' homes, it's found on their cell phones, on the door handles. If you go into our environment within the hospital, areas, certain high-touch areas will have that virus present. And we've tried to fashion mitigation in terms of environmental cleaning, the messages to our patients and families to try to decrease the potential fomite spread. This is not an inconquerable virus. We can kill it with soap and water. We can kill it with alcohol prep solutions and bleach solutions, which are widely available in terms of the concentrations online. One of the big stories that's still holding true is that this is a very contagious virus, and part of it is because the viral concentrations, if you look at this slide on the left-hand side, it's based on symptoms, all the way from asymptomatic to symptomatic, and then the CT value scale on the bottom is showing you the lower the number, the higher the viral load. So there are there's a high viral load at the beginning of infection, which was different than other SARS viruses or MERS in the past, increasing the likelihood that you are contagious, very contagious, even before you start your symptoms, and potentially even if you're asymptomatic. This is a slide touching on that same type of issue, that at the beginning of infection, the viral load is very high, even if you're asymptomatic or pre-symptomatic, which increases your risk for transmitting it to other people. What about diagnostic testing? Diagnostic testing is coming along. It's still an issue that has been hotly debated in the news outlets. We do most of our diagnosis, and still do, for active cases with reverse transcriptase polymerase chain assays. That's the PCR. And there are multiple PCRs available. We talked about the isolation from different sources. The timing of when you're sick also will affect the yield of the PCR, and the PCR duration of shedding over time as you recover from illness. All those are hotly debated topics. Serologic testing is hotly debated also. You can demonstrate that patients develop IgM, IgA, and IgG. And there are different qualitative and quantitative tests. Qualitative meaning you just get a positive assay, quantitative actually giving you a titer. The antigen test is the most recent FDA-approved test. That's where you're using an assay to diagnose part of that protein in either a nasopharyngeal or nasal specimen after the swabs are added to a viral transport media. Sensitivity of that test, and the benefit of this is, for example, in many offices right now, they have these setups for doing flu antigen or strep antigen. It's a similar technology where you're just trying to test for that antigen. But remember that the sensitivity of this particular test, which was approved under the EUA, which, remember, again, these are small samples that they get their approval, and because of the pandemic and the emergency aspect of this whole illness, they're approved without large validation studies. But nevertheless, this antigen test is anticipated to be potentially used in offices, but the sensitivity is only 80%. So that means if you have a negative test, 20% of the time you may be missing a true positive, and that needs to be confirmed with a molecular test, the PCR. Here's serology. Now, when we last gave this talk, we had 3 or 4 serology tests approved. At this point, if you go to the FDA site, fda.gov, 12 tests are approved. But of note, I kind of highlighted 2 differences. For example, in the Abbott test, which is an ELISA test, the IgG sensitivity was 100%. But of course, look at the number of specimens tested to get that sensitivity. It's only 88 specimens, but still, it was a pretty good test. If you look at the Celix test, which is that rapid test lateral flow assay, rapid test, where, like a pregnancy test, you put a drop of blood and boom, you have a line that shows an IgG, IgM, or both. But the sensitivity of that test is only in the low 90s, and again, only testing 128 specimens. The importance of that is, if you read along the lines on the Abbott test, if you have a prevalence of disease of 5%, having a positive test is more valuable in terms of giving you true information. That has a positive predictive value of almost 93%. But if you look at the Celex test with the same parameters, 5% prevalence, the positive predictive value is only 50%, meaning it could be a false positive or could be a true positive or a false positive, so it's not as helpful. Really depends on the parameters and prevalence in terms of how you're going to use some of those serologic assays. And remember again that serology at this point today, 5, 12, 20, doesn't necessarily mean you're immune. It doesn't measure neutralizing antibody. We don't have good correlation yet between a positive IgG and saying truly you are immune to the disease. Don't memorize this slide, but just showing you these are the types of calculators that are out there to figure out, you know, sensitivity, specificity, positive predictive value. If you go on to Google it and get a medical calculator, you can figure this stuff out yourself and figure out how valuable a test may be. Nothing to memorize. Super spreading events, still important. We talked about Spring Festival in Wuhan and 5 million people leaving after that, having one event of 40,000 people, one dinner and 40,000 people in Wuhan, nice way to increase the spread of the disease. Mardi Gras in New Orleans, church events in California, and still going forward, taking that in mind in terms of planning for events that we anticipate may be coming in the fall. Are we still going to be able to have large sporting events, big concerts, et cetera? What's going to happen with that? Every person that gets COVID probably infects 2 to 3 persons. Looking at our epidemiology in the very beginning, there was the first wave of infection where you had somebody coming from Wuhan, landing in Seattle, infecting a nursing home, and then having limited community transmission. The second wave, which is early March to now, is the story of community transmission within cities, probably affected by population density, events that were going on, the differences in each governor's institution of social measures to try to decrease spread. And then now the third wave, which is early April to present, has to do with some of the other stories that you're hearing in the media. For example, what's going on in the prisons. And it's still an issue of conglomerating populations, gathering those populations, and then if they're not well set up and suited to measures that prevent transmission, whether it's social distancing, whether it's having a private area, trying to get away from having group gatherings, you have spread. You have spread also to the workers in those environments who go back into the community, and then that outbreak continues to occur. In the prison systems, prisons are known to amplify outbreaks. This is not an old event. In fact, if you looked at the Spanish flu in 1918, half the inmates of San Quentin became infected with the Spanish flu. And currently in our own state, we know that we have institutions such as the Green River Correctional Complex, which has a significant number of inmates, 400 inmates infected. Inmates at FMC started out at 57, has gone up to over 200 now by report a day ago. And employees also being positive, we know that some of those patients are ending up in our local hospitals. If you talk about surrounding states, the Marion Correctional Institution in Ohio had 2,000 out of 2,500 inmates positive for COVID-19. Rikers Island having cases, started out with a few cases early in March and then exploding. Same with New York City jails, 300 cases amongst the inmates there. There's about a 10% infection rate. 2.2 million persons are in prison in the United States, but also importantly, we have people circulating through. So the average length of stay in a prison system is 25 days. So there's a big turnover where you can get infected, go back into the community, and again, amplify the outbreak. It's also an international issue. It's clear that many prison systems throughout the world are overcrowded, hygiene conditions are difficult, and that is an ongoing story with many different countries. Meat and poultry workers are also being affected. An MMWR article came out over the last week talking about COVID cases amongst U.S. workers in 115 meat and poultry facilities reported by 19 states. That's 130,000 workers affected, a 3% rate. But of interest, again, there's a range of each poultry plant being affected. In some places, it was only 0.6%. In other factories, it was 18%. And there are deaths associated. If you look at the entire industry, it employs about 500,000 workers. The risk was associated with workplace physical distancing, hygiene, crowded living conditions, and transportation conditions. So they are trying to reorganize how they set up their plants. This is a Tyson food plant in Waterloo, Iowa, where they're putting up shields and they're trying to mask workers to prevent transmission while they're working on the lines. How effective this will be difficult, because clearly you can't use a surgical mask. That'll be soiled fairly quickly. I have actually worked some outbreaks before going into meat processing plants. It's very messy in these plants. It'd be very hard to maintain good conditions. You have to use something more like a shield where you can clean it. But it'll still be a challenge, and we'll see how that works out. Healthcare workers, in terms of occupation, are still an issue. This was the original report back in middle April, showing that 3% overall of cases in the United States were involving healthcare workers. But again, the data are not routinely reported in each state. When you do have that more robust reporting, about 11% were positive. It's also going on in other countries. If you look at, this is reporting from London, the red line are cases in the community in London. That's a lockdown was instituted March 23rd. The blue line is admission to hospital. You can see that the curve went up and down. And then the bar graph is actually healthcare workers. Of note, so at the height of the epidemic, healthcare workers were affected about 9% of the time, and it mirrored a lot of what was going on in the community. It wasn't higher than the community, showing that really transmission probably was more related to community acquisition, not hospital acquisition. As the outbreak goes down, so does the caseload in terms of involving healthcare workers. So that, in some respects, is comforting. There have been a meta-analysis, if you will, of all the available data. Remember, at this point in the outbreak, there are 10, 15,000 articles written on many different things. One particular review from the Annals of Internal Medicine just last week looked at healthcare worker risks and all the information involved, trying to analyze all the different data. The incidence in healthcare workers varies depending upon one study. Remember, the initial Wuhan study quoted 3.8% of healthcare workers being infected. But if you look at different reports coming in, it could be as high as 38.9% of healthcare workers being infected. The prevalence, by looking at serology, ranged from 0.3% to 40% in 6 studies. One of the highest reported healthcare worker outcomes was in Vietnam, where they didn't have isolation wards. Now, that story, again, is not uncommon in previous outbreaks for other countries, regardless of which disease you're talking about. If you don't have the resources, you will get your healthcare workers sick. So risk factors, if you analyze that for healthcare workers, include suboptimal hand washing, improper use of PPE, and having a diagnosed family member, which again tells you the story that you can do everything right in the hospital, but you can still get sick in the community, especially if your family member is sick. Risk reduction is most consistently seen in these studies with proper use of masks. That's surgical and N95. Most studies also found improvement with the use of PPE, gloves, gowns, eye protection, shoe covers, associated with a decreased risk for a healthcare worker infection. Currently in the U.S., we have 1.3 million cases 79,000 deaths. It involves everything. The first case, remember, was now identified by the medical examiner on an autopsy study in February. Initially, it was thought the first death was related to somebody in Seattle, but that was sent off and verified. So it tells us that some limited community transmission was occurring earlier than thought. The testing is interesting in the sense that some of the, if you over the time course, you're going to have an increase and decrease of what percentage of specimens are positive. So as the outbreak increases, the percent of specimens that are testing positive will actually tend to increase. So if you look over the past 2 months, the percent is actually going down a little bit. So 15.7% of specimens being tested are positive at the public health lab, 18% at a commercial lab. We've done now this is cumulative, 4.8 million tests done since March to the present. Hospitalization rates are still going up. They're not going down, but they're still going up. And part of that is that the data kind of lags behind in terms of gathering that data and then telling us where it is. The overall hospitalization rate at this point is 50 per 100,000. Very high in those age 65. That's 162 per 100,000. And also even 50 to 64, 79 per 100,000. Here's a historical slide. Wow, this is March 12th. It's 700 cases at that time. And that, you know, you look at the curve, you always got to look at the left-hand side to see what the numbers are. So this is total number of cases. Total number of cases at that point were 792 cases. It's a little bit different now. So this is new cases by day. So you can see these are thousands on the left-hand side. So that was a total of 700 cases back in March. Now per day, we're talking about still, you know, over 30,000, 20 to 30,000 cases per day. So we've come a long way. But if you look at the overall curve, these are 7-day averages also. The curve is actually going down some, in my respect. It's not going up. And probably the overall curve for new cases per day is slightly decreasing. But it's not the same for every state. You still have the color-coded map that you can find on CDC's website in terms of hotspots. Northeast and the West Coast are still hotspots. Kentucky there is staying steady. We have 6,000 some odd cases. So the outbreak is not simultaneous. Remember that it's different in different states, and the stories are different in different states. So that is still an ongoing, which makes it kind of difficult. So from a national standpoint, you're trying to come up with guidelines that are applicable to everybody. But from a state standpoint, you got to look at your own population and make decisions. And of course, what happens in your own state, you're still affected by the neighboring states because there's no such thing as a free movement of people between states. Here's Kentucky. That was, as of yesterday, we had 6,677 cases. We still have only tested 100,000 people. That's, wow, we got to do better than that. And we will, I think, as our resources increase. 311 deaths. We declared an emergency on March 6th. Our peak cases probably happened a couple of weeks ago. If you look at the breakdown of who's getting sick, 74% white, 15% black, 6% Asian. And it's really pretty much half and half in terms of male-female. Cases per 100,000, we're still on the, much lower than New York as the gold standard. Here's our epidemic curve model. At this point, you can see in terms of our resources, ICU beds available is the green line. The purple line's all beds available. We're way below any capacity. There's no issue in terms of bed availability, and our caseload has really dropped off, which is good. Here's our infection and testing curves. The dark brown is our confirmed infections. The blue line is our testing. And as capacity has increased, that curve will continue to go up. The blue line will, but hopefully that brown line will flatten out and actually go down. So there's not been a dramatic increase. If you look at percent of specimens that are testing positive now in our hospitals, it's probably still less than 4 out of 100 specimens testing positive. Death rate is flattened out and going down. It's still a communicable disease. Measles is still contagious. The reason why it's not contagious right now is because we have good vaccines that prevent it. SARS is SARS-CoV-2. It's still really contagious. But as the disease goes away, it doesn't mean that it changes. It's still contagious. It's just not as prevalent right now as we might see. So as the cases go down, here's what tends to happen. People forget that it's actually out there. So just like they forget about measles. Nobody thinks about measles until you have a big flare-up, and then you got to change your vaccine policy or do something else. So that's a challenge when it comes to these types of outbreaks. Now, I apologize for the next 3 or 4 slides because I said I was going to touch on immunology. Immunology really is kind of like a rabbit hole. You could go on and spend 10 hours and actually fall asleep probably learning about T cells, B cells, cytokines, et cetera. But you got to understand that that is part of what is going on with this illness. You have a viral infection and you have a robust immune response that is really having some collateral damage in terms of people's outcomes. So we got to look at that type of stuff. If you look at the virus itself, it has an anatomy in terms of parts to the virus. I've talked about the spike protein and the different aspects. The E protein probably being related to virulence. The virus has these different parts. It's an RNA virus, and you can break this down and look at differences. You can even look at molecular differences. For example, we know the virus is changing slightly, and there's even a whole branch of molecular virology looking at different changes in the virus and tagging it to different countries, so it has a fingerprint that you can look at. So there are benefits to looking at all these molecular things. If you look at the pathogenesis, it does attach to an ACE2 receptor similar to the original SARS, and these ACE2 receptors are distributed all over the place, including your lungs, GI tract, oral tract. This is not to memorize, but just to give you a general idea. Again, it attaches to the receptor, and then it goes through using the cell's machinery to create a new viral particle. It gets phagocytized, and it starts a pathway of a lot of these cytokines and chemicals that will cause injury. They're also there to try to benefit the body in terms of recruiting the right cells to kill that virus. And there's a whole language of cytokines, cells. There's a whole language of talking about innate immunity where macrophages are involved, and adaptive immunity where T and B cells are involved, and they produce antibodies to deal with specific organisms. It's way too complicated to go into. Here's part of the nomenclature. If you're looking at cytokines themselves, on the left-hand side, interleukins, interferons, tumor necrosis factors, chemokines, growth factors, and some examples. Look at all those ILs. I mean, there's a lot of ILs standing for interleukins, a lot of interferons, if you look at the interferons in terms of alpha, beta, and gamma. And they all have different functions. So while we talk about the basic epidemiology, now we touch on a little bit of the immunology, that all these chemicals and processes are going on, and they all have consequences. So while we don't see any of this stuff, but they are recruiting cells, they're trying to deal with the infection. And on a big gross level inside your blood, you have these cells going on. They're being stimulated to try to fight the new pathogen, this new SARS-CoV-2. Some of these cells go into your lungs. They cause, by actually secreting to try to help the body, they actually have a collateral damage in terms of causing some edema, exudate, inflammation, ARDS. So that SARS-CoV-2 is being attacked. Your immune system is trying to deal with it, but at the same time, there are many different mechanisms, like we've talked a lot of press about IL-6, where IL-6 will attach to receptors in your body and then start a whole pathway of these chemicals and chemokines, which eventually try to lead to your T cell and B cell working to try to eliminate that infection, but at the same time causing side effects in the body. So this is not, this whole concept of inflammation and downside of the inflammation is not new. I mean, it happens in a lot of different infections. It's also similar to previous coronaviruses. So previous SARS and MERS patients had increased concentrations of these inflammatory cytokines. And if you look at the pathology of the lung, you could see the result of all the recruitment of these different types of cells with their markers and the side effects of having some lung destruction, fibrosis, and some of the consequences which may eventually end in death. The next couple of slides I don't want you to look at. They're there for you to reference, and they're basically talking about one of those cytokines like IL-6, which is getting a lot of press. It's a polypeptide. It's produced by a lot of different cells, and its activity is there to help the body. It's trying to, it binds to a receptor. It causes a downstream activation of other cytokines, and it's there to try to help with differentiation of your T's and B cells, try to improve your immune system. But the downside is that it's also an inflammatory chemical, which can lead to some overexpression and damaging to those tissues. So it promotes T cell populations and expansion, but it also causes some downside side effects in terms of inflammation. And sometimes the balance of these factors, especially with a new agent like SARS-CoV-2, ends up causing more damage than benefit. Hence, we talk about blocking that IL-6, which combines to that receptor with a drug such as tocilizumab, which tries to block either the membrane-bound or the soluble-bound receptor that IL-6 tries to attach to. And then it blocks that signal, and it tries to decrease the inflammation and allow your body to heal. So I've taken you down the rabbit hole, but this is where most clinicians tend to focus on, and that's the clinical aspect. So all that stuff is going on in the background. You have a very complex immune system. You have a new organism like SARS-CoV-2. You have the big picture of the epidemiology. Now we have the patient that's in front of us, and the patient that's in front of us, that's what we tend to deal with at the hospital level or at the office level. So the symptoms are typical. They're not unique in some fashion. So we have the fever, cough, a lot of viral type symptoms, but we have some damage that can occur while this immunologic stuff's going on, the cardiac injury, the lung injury causing hypoxemia, and ARDS. And then we have some of these unusual things that have been discussed, such as potentially Kawasaki's in kids, or the loss of smell and taste, that's dysgeusia and anosmia. We have some rashes, neurologic symptoms. We have some other unusual symptoms, which in previous talks we've talked about, and if you want to go back to the website, you can pull up some of those slides. Clinically, it's not easy to distinguish this from another viral infection. So that there's not one that when that patient walks into the office or walks into the hospital that will be a red flag. So we have to use our previous knowledge potentially of exposures, which is what we do when we talk about screening, where our person's been, some of the symptoms that may tip us off, this is a viral infection, what's going on in the community, could this be COVID? And then looking at the syndrome itself, it tends to be a viral illness where most people, 80% or so, are not going to be that sick in that first week, but then there's a transition point after that first week where they can actually, things go haywire related to some of those immune issues that we've previously discussed. Those are the patients that are getting over the tipping point. They start to be more tachypnic, hypoxic, and meanwhile, the viral load is decreasing and you have this immune system that is kind of going out of whack. Most people take about 4 to 7 days before they are admitted. Here's some typical x-ray findings. We've seen this before. On the right-hand side is an Annals picture. Now, the yellow arrows, if you look carefully there, that's a chest tube and pneumothorax. So barotrauma has been part of this illness, especially in patients that have required intubation and required high PEEP as a side effect. Immunosuppression and HIV. There aren't a lot of case series reporting in terms of the clinical illness. If you look at immunosuppressed patients, it's not as much of a factor as their underlying comorbidities. So having uncontrolled diabetes may be more important than having a history of cancer. And if you talk about HIV, same thing. It's not, most of these HIV patients, the series are small. It doesn't seem to be a disease that's out of control in HIV. So it may be if your HIV is out of control. So your CD4 cell count's 2, and you're not taking any antiretroviral, you're more at risk to crash from a lot of different reasons. But what the literature tells us right now, it's not really disease. It seems to be, that's not a red flag that comes up. Children overall, initially when you looked at the Chinese data, it was not a severe illness. Little evidence for perinatal transmission, inconclusive evidence regarding breast milk transmission, so most studies did not report that, although there are some papers showing potentially that breast milk is infected. The overall, there's no change in the recommendation. Most are not hospitalized, and they typically have a viral syndrome. And of note, as time went on, this whole story of asymptomatic kids has been discussed. The reason for less severe disease is not clear. It may be related to their immune system. They have a more robust level of T cells than, say, somebody who is 80. There's some T cell senescence that occurs. And it may also be related to their ACE2 receptors. They don't have the same amount of ACE2 receptors at a very young age compared to an adult. So all that stuff is being evaluated. If you look at the United States data, similar thing. This is comparing pediatric to adult presentation clinically. They're very similar. Not a lot stands out in terms of differences. They have runny noses. They have sore throats. They can have some abdominal pain and diarrhea, but also not that much different. On the right-hand side, you can see who gets hospitalized. Again, the dark line, the dark part of that graph is not hospitalized. The majority don't get hospitalized. That's broken down by age group, unless you're under 1 year old. So under 1 year old, you might have a more likely chance of being hospitalized, but otherwise, that's not the case. Kawasaki-like syndrome has been given some press recently. It's the most common cause overall, Kawasaki's disease, of an acquired heart disease. It's an acquired vasculitis. Typically happens in those less than 5 years old. And the classic Kawasaki's is clinically diagnosed with a fever and then criteria including conjunctivitis, lip and tongue redness and swelling, and a rash, and then some swelling of the hands and feet. So initially, Willie wasn't reported in China, but then in Europe, it started to be reported in France, where they had patients, kids in the ICU, and now also, and in the UK, and now also reported out of New York City and LA County. So that is an ongoing syndrome that's being looked at more carefully. Some of the articles are discussing it as a pediatric multisystem inflammatory syndrome, and that's more to be discussed. So in general, symptoms are not specific. Labs aren't diagnostic. There are some labs associated with worse disease, which we'll touch on later. You can shed the virus for weeks. That's been an issue in terms of people getting back to work, especially healthcare workers, and that's still under debate. Not a lot of studies, enough studies, let's put it that way. Not a lot of studies. There's small studies, like 9 patients, discussing, and I know there's studies that are going to be published, because we talk to people that are doing it in the academic centers, and they say, yeah, we're doing it, and we're finding this. Like, they have a positive PCR, but they can't actually detect the virus after X days. Usually it's 9 to 14 days. They can't detect the virus. But those studies aren't published. That's just what they say. So as in a lot of this outbreak, there's a lot of what is said, and there's less that's actually published in a peer-reviewed journal. So here's a summary slide looking at the red is a typical mild disease, 5 to 14 days, and then severe disease can occur in a smaller percentage of patients, and trying to correlate that, showing you that the initial part is the viral response, and the secondary part of the illness is probably the hyperimmune response, the cytokine syndrome. Your PCR viral load is high initially and then goes down over time, and your antibody usually start to begin within that first week. Depending upon how sick you are, your age, et cetera. Severe disease occurs usually at the end of the first week and varies depending upon which series you read. ARDS can develop 18% to 50% in those patients. You can have acute cardiac injury, acute kidney injury. All depends upon which series you're reading. Severe illness, though, is probably about 10 to 15%, more common in those that are an older age group. What kills patients is still probably ARDS, thromboembolic disease, myocarditis. There was one prospective study looking at 12 consecutive deaths with doing autopsies on those patients, and they were surprised that almost 60% of those patients had thromboembolic disease that was unrecognized. When they looked at the presence of the virus, they found the virus everywhere, high concentrations in the lung, and virus in lung, kidney, and heart. So with that in mind, we can point to what are the types of clinical monitoring that we do. Similar things, we're looking at O2 sats and respiratory rate, and then doing some daily labs that are written there. There are some predictive, people are still writing, there's people that are writing articles about, here's the pre-existing data set, we generated a formula, and then we applied it to another data set of patients either in their own institution or in another place, and see if they can predict who gets ill. Lots of different types of articles like that. It's like using an Apache score and a SOFA score, and they develop these types of COVID scores to try to apply it to a data set. It's still in a state of flux. But if I try to highlight some values that seem to be consistently reported, that is taking into account comorbidities, age, developing respiratory failure, looking at respiratory rate, and then some labs, such as their oxygen saturation, D-dimers, ferritin, and CRP. Remember, though, here's the reverse thing, and this has happened in the hospital. We'll get a consult for somebody who has an elevated ferritin level and with the diagnosis of COVID. An elevated ferritin level doesn't give you a diagnosis of COVID. Neither does an elevated CRP. These are just labs. And if you take a lab, whatever the lab value is, and you just use it uniquely, it's not pathognomonic. It's not the diagnosis. It's everything involved. So remember that there's a differential diagnosis for an elevated ferritin, differential diagnosis for an elevated CRP. Just because you have those doesn't necessarily mean you have COVID. So that doesn't make it easy, but I'm saying if the patient fits the picture for COVID, those are some values to take a look at. But in and of themselves, they don't make a diagnosis. So general guidelines still hold true. We try to shorten the length of stay. If any hospital, we try to pay attention to how often we're accessing the patient. We try to pay attention to other parts of the patient and other patients so that we're not neglecting our other patients that have heart disease or cancer or whatever that may be. Supportive care is still important, so oxygen is probably the most important supportive care measure that you're going to do, and also watching your volume status. Initially, there was a lot of panic over use of ventilators, so there were studies that were reported about Johns Hopkins saying we need X number of ventilators, especially if this is similar to X outbreak in the past, whether it's Spanish flu or 1957 influenza epidemic. But at the same time, now that we have a little bit of distance and perspective, we're starting to see articles crop in discussing measure response to outbreaks. It's always easy in retrospect to say, well, we should have had 10,000 more ventilators in New York City because clearly that was a mistake. But then, you know, if we had 10,000 extra ventilators in Lexington, that would have been too many ventilators. And we might have actually taken away resources for other measures which might have had a better effect, such as buying better, more PPE, putting resources into social distancing and those measures. That actually may have saved more lives than actually having 10,000 extra ventilators in Lexington. But it's hard to make those arguments because, again, all this stuff occurs also in the context of hysteria, panic, fear, the unknown. And you can't win on either side. There's always politics going on, and while you think that that's not involved, it tends to be involved, and nobody wants to make a mistake. Very difficult to make some of these choices from a national standpoint and also on a local standpoint. So just take everything with a grain of salt. They are trying to use evidence-based. They are trying to use measures to face some of these facts. But there's a good Annals article there from the 7th of May that kind of discusses some of that. Antibiotic use is still very common, although the number of people that have true bacterial infections is probably low. When you're talking about a typical case, probably 5% or 5 to 10%. The longer you go, the more likely you are to have a secondary infection potentially in terms of a nosocomial infection, but as the onset, not so much. Anticoagulation is important, especially in those with D-dimers. Taking that into account, remember that autopsy study I reported that 60% of the time in those autopsied cases, they found unrecognized thromboembolic disease. Some of it clearly related to the cause of death. So take that into account. Different places have different measures that they look at in terms of D-dimer elevation. Some places use greater than 5, some places use greater than 3. I don't know. There is nothing that is a gold standard, but paying attention to it and trying to come up with an algorithm would be important. Time course of respiratory failure, we talked about that previously, and that is that you have the initial where you have some shortness of, you might not even feel the shortness of breath because you have, your compliance of the lung is fine, but over time that can be triggered, and you have to be careful about that's why I say watch that respiratory rate, watch the O2 sat, and you transition to a more severe disease. That's when you start to think about measures to get you over the hump. Not everybody that develops an increased O2 requirement will require immediate intubation, and that is different now than we were at the start of the outbreak. At the start of the outbreak, the message was as soon as they get more short of breath and they're going toward an increase in their terms of O2 sats, an increase in their liters per minute requirement, let's intubate them soon. That kind of has been modified to looking at patient initially as when they have good compliance, try to use other measures, including non-invasive ventilation, and then as you go toward intubation, trying to still using proning, different measures to try to protect the lung from ventilator-associated lung injury. So what about treatment? Now, treatment, when I'm talking about, we talked earlier about these are supportive care treatments, oxygen use and watching fluids, a fluid status. You don't want to overdo the fluid status. Now, what about medicines? Because always we think about treatment, we think about medicines. And I thought I put this in there because this is in the context of previous what's happened in history. This is a outbreak that is clearly, in my lifetime, it's a pandemic. There's really nothing to correlate it with. There's a lot of panic and fear. So we want to do everything possible to save our patients. But remember, historically, we've faced similar things that none of us have been alive to remember this, but back in the Spanish flu, back in the World War II, there were lots of different pushes to get things done because you want to do something. And that also has led to sometimes adverse consequences. That's why we have to, it's a balance between trying to do the best for our patient using data and trying to not succumb to panic to do anything, which may end up hurting. So if you look at previous national emergencies, we had that Manhattan Project, and sometimes they talk about this as the Manhattan Project to fix COVID. But we had previous national emergencies during World War II, mass production of penicillin. These were good things. Polio vaccine, 1950s, promoted by Joe DiMaggio. He used to be a famous baseball player. And Lucille Ball used to be a famous comedian. Nobody remembers them from now, but that was back in the day. But pressurized research, pressurized situations also led us to formulate things that had bad consequences. So we formulated vaccines that ended up giving GIs hepatitis. We accelerated vaccine development for the swine flu when people were worried about the threat to the U.S. in the 1970s and ended up having Guillain-Barré, which actually negatively impacted public health. And from the CDC to the NIH to all these areas, they got negatively impacted where people didn't believe anything about public health. And it actually took the Legionella outbreak to help restore some of the confidence when they figured out Legionella that public health may be okay. So we have to be caution in terms of how we approach treating our patients. As I mentioned before, we're using a lot of non-peer-reviewed information, especially on sites like medRxiv, which is that pre-publication site. The majority of those articles, of which there are 300 pages worth of articles, are non-peer-reviewed. They're not published. And we got to be careful about driving treatment decisions based on some of that information. We want to do the best, but we also got to be careful where the data comes from. So it is difficult to balance the tensions between doing something and practicing evidence-based medicine. So with that being said, we go into treatment and what has been done. First of all, there are no acceptable medicine treatment for this, but there are things that are under investigation, and in some cases when we do not have access to clinical trials in community hospitals like our own here and in the city, we are using some of these medications. So steroids initially were thought to be, nobody should get steroids, but that has been somewhat changed over time. It may have a role in ARDS and shock and the cytokine storm. Medications that have been having more press include remdesivir, the plasma, tocilizumab, and steroids. We have lots of vaccines underway. Remdesivir has gotten a lot more press recently. Initially, it was developed for Ebola, but let's go through some of what's available in terms of published literature. You had that initial study with compassionate use out of New England Journal that said there was potentially some benefit. Remember, it's really not a big study, but it showed some potential improvement in terms of oxygenation. And then we have strange data, what I call strange data because 2 out of the 3 studies here are not published. They are press releases. So the original one, this interim analysis of 1,000 patients, that was Dr. Fauci's press announcement and Gilead's press announcement. But that data are not available for evaluation. So we do have some generalities. So they studied over 1,000 patients, and they had some improvement, potentially, of faster recovery time, but no significant change in mortality. But that was a ray of hope, so that was given at a press conference. But still, to this date, I cannot find any of that information, either on the preprint server but you can find it on a press release out of Gilead. Chinese study of 237 patients showed really not any significant change, and then another press release showing a similar outcome between 5 and 10 days of remdesivir. So it's just a little bit bothersome now. I tend to notice some of the data that are being reported now, and this is like months into the outbreak, by some of the bigger companies like Gilead and Roche are actually not available or not published, but they are available in press release form. So that makes it a little more difficult to evaluate. Nevertheless, that may be that is probably a drug that will be useful in the beginning of infection. Hydroxychloroquine has had a long journey, which started with the in vitro data, which showed improvement. But at this point, it's not routinely recommended outside of a clinical trial, although there's always caveats when you go to people's websites that say if you don't have access to a clinical trial, then you can consider it in patients that have respiratory failure and they look like they're sick, and here's the dose, which is pretty much in every place a 5-day trial of use, sometimes up to 10 days. And there are data accumulating, but the data also are not they're not big randomized clinical trials. They are data that have lots of caveats that are interpreted in the media as being a pro or con. Sometimes, from my perspective, it depends, almost becoming a little bit partisan in terms of how they're discussing some of the data. But look at some of the studies. So initially, if you look at NIH and IDSA guidelines, those are national organizations, they still say use in clinical trial, but they're still talking about it in use in a clinical trial because the data are not definitive. There was a premature discontinuation of a high-dose trial in Brazil. That trial really was not a very good trial. It used very high doses. Every patient got azithromycin, and they had cardiac toxicity, which was not unsurprising. Now there's some retrospective studies looking at groups of patients. They're not looking at, there's no comparison to try to figure out, randomizing them to try to figure out whether it's truly related to the hydroxychloroquine, so difficult to interpret. The VA study had 300 patients, and it showed an increased risk of death in patients with no change in ventilator use, so it didn't seem to be as helpful. There's an open label trial in China, 150 patients showing no benefit in terms of viral seroconversion at 28 days, and did show some increased toxicity. And then New York has reported 2 large, basically retrospective studies of over 1,000 patients in each study. One showed no association with death, and one showed no difference in outcome. So not a lot of supportive data for hydroxychloroquine. Cardiac toxicity is still a main concern with QTc prolongation. A lot of our old patients have other medications that may prolong QT, so you need to use it if you're going to use it with that in mind, monitoring EKGs to make sure they don't get sick. The retinal toxicity is not generally an issue. That's usually with long-standing use. But that's still a drug that's not completely gone away, and we still have to wait for some of the randomized clinical trials. I think if you're in a small community hospital, that's still a potential drug to use, especially if you have no access to anything else. This is what we talked about before, the immune therapies using tocilizumab. So immune modulators are for that cytokine storm. It's an antibody that blocks the connection between the IL-6 and its receptor and all the hyperinflammatory stuff that may resolve with that. Criteria for use, basically, if you're not in a clinical trial, is looking for the evidence of that cytokine storm. So if that patient starts to become more febrile, increase in those biologic markers such as CRP, that's probably the time to use it, not when they're already full-blown in ARDS on the ventilator and having difficulty. So there are not a lot of trials still published. Here's a trial in France. It looked at 129 patients, and it showed that certainly the biologic markers improved, and 15 patients in China showed some improvement. 100 patients out of Italy showed some improvement, but these are small trials and they're not overwhelming. They can say 77% of patients improved, 23% worsened. Some did develop sepsis that were treated with tocilizumab, and tocilizumab can be associated with infection. So it's not, and here's 25 patients from Qatar. So if you notice that a lot of the data are still small numbers of patients, and it's hard to generalize that, but we know that it does seem to, having used it, and our group having used it, it does seem to, we have not had any adverse consequences to it, and it does seem to really cool those patients off in terms of their inflammatory markers, and it has helped, I think, get them off the ventilator. Steroids, same thing, no new data. Remember that we're using data from the ARDS trials to try to look at using steroids, and that they have some benefit, especially in ARDS, to be at least recommended by some of the critical care associations. So in those patients that have a significant cytokine storm and ARDS, there may be a role. Whether or not you use it concurrently with another immune therapy like tocilizumab, that's not clear. Whether you use it as a rescue medicine, if tocilizumab doesn't work, adding it, that's not clear. But different institutions are doing different things. Convalescent plasma, there's no really new information. Remember that is, we tried to take information from previous outbreaks using meta-analysis that, especially in this time and place, we still have no definitive therapy, that using somebody who recovered from SARS-CoV-2, using their immunity to try to help somebody else recover. And although you could argue we don't have any definitive proof of immunity right now, but at least we know they produce antibodies. And there are some data, for example, in an animal model that you can, and this is a small animal study, that if you try to reinfect them with SARS-CoV-2, and this is, I believe, in a macaque model, criticize me with an email or something if I'm wrong, but you can actually have some protection for a limited amount of time when you try to reinfect those animals. That's probably the only model showing that there is some immunity. We have neutralizing antibodies that are a surrogate for immunity, and we know that you can actually have antibodies that protect you in this model for neutralizing antibodies in a cell culture media dish. So we know there's some benefit to develop a IgG response. So using that data, using convalescent plasma from the past meta-analysis, we are using convalescent plasma to try to treat our patients as well. And there are small series like this 5-patient series which showed potential benefit, and here's a 10-patient series showing some potential benefit. They do seem to seroconvert when you get it, but there are still no large series. We still need evidence of what is truly going to reflect immunity. Nevertheless, it's an ongoing effort that's gained some momentum in the community and nationwide. And if you look at Mayo Clinic expanded access, that is where most of our local hospitals are attached to right now. They actually just received, as of within the last week, $26 million to try to further this effort of showing benefit for convalescent plasma. On the right-hand side, you have monoclonal. So in the future, we may actually be developing monoclonal therapy. So for now, that's not ready for prime time, but monoclonal therapy may be the answer, where we have mass production and measured effect of a monoclonal antibody to treat SARS-CoV-2. Lastly, in terms of therapy, this is something that just came out over the past week or so. Lopinavir, ritonavir had one study published in the New England Journal where it showed a lack of benefit, wasn't beneficial. Part of that study and the trickiness of all these studies really depends on when you use the therapy itself. So using a therapy at the beginning of disease is not the same thing as using a therapy when you're in ARDS on the ventilator and just about to go out on 4 pressors. Those two patients are different, and the effect of the medication may be different. So a lot of times when we start these studies, we just give them, especially now, we give them oftentimes to the most sickest patients and then publish saying it didn't have much of an effect. But that may actually not be, as we get more information, we start to learn where to place those medications. Maybe those medications should be used in the beginning. So lopinavir, ritonavir basically got pushed to the side because they're saying it wasn't effective. But here's a study that says maybe it is effective. Now, they were using it a little earlier in the course of disease. They also added interferon beta and ribavirin. And in this study, it says potentially some benefit for using this combination. But it's only, again, 127 patients. So how do we put all that together? We say early on, probably need to use antiretrovirals, antivirals, not antiretrovirals, antivirals, remdesivir, maybe hydroxychloroquine, maybe lopinavir, ritonavir, interferon, those types of medications. As you progress, using convalescent plasma. And then potentially, if you start to get into the dysregulation of the immune response, using immune control, whether that's tocilizumab, sarilumab, JAK2 inhibitors, steroids, et cetera. There's going to be some role for that, and how to do that is still going to take time. We're going to have to gather the information and do the studies. So we're moving forward. Here we are in the 12th. We've started to open up some surgeries. We're still doing identifying patients, isolating using PPE, engineering, and administrative controls. Clinics are moving forward. They're starting to open up. They're using the same techniques, identifying patients, trying to utilize telehealth if possible, using PPE within their offices in terms of masking patients and healthcare staff right now, emphasizing hand hygiene, and still having environmental and administrative controls within their own clinics. April 27th, we started the phase 1 reopening. We're now, last week, we started the beginning of ambulatory invasive surgeries and started our pre-testing. And lo and behold, pre-testing works. So we did find there are people that get pre-tested that do have evidence of having SARS-CoV-2. And that's the whole purpose of establishing a process and trying to protect healthcare workers and other patients. So we do have some positives, and we have those processes set up. Those people get rescheduled for a later date, and people get protected downstream. We're still maintaining our PPE. We're still maintaining bed capacity. Now, starting tomorrow, we're not having a surge, so we're still moving forward with our inpatient surgery at 50% volume, still testing, and then by the 27th, opening up for all elective surgeries and continuing our testing and maintaining our bed capacity and PPE. So our last 2 slides are their controversies. Of course, there are controversies. Probably the biggest controversies now are that discussing the risk-benefit measures for control. So that's going to be discussed. Each state and each governor is trying to give their message. They're not all the same. Some states seem to be doing other things. Some states seem to be doing not really looking at guidelines. And each state has got to do their own thing, but try to use principles of infection control, public health measures, and what's best for their population. So it'll still continue to be debated and probably related to local amount of disease burden. You're going to have people arguing about masks, people arguing about gatherings, flaunting public health measures, opening up their restaurants and saying, look at me, nothing's happened. But of course, nobody understands that this is still invisible in terms of, most people do not see the downside delivery of some communicable disease. So somebody's grandmother eventually is going to be infected, and maybe infected because of your whatever reckless opening up of something without any considerations for public health measures. That has been well documented during this outbreak, where gatherings have been tracked down to deaths. most people at the beginning of that transmission, they don't see it because they don't see the attachment to this thing. And we don't have a lot of feedback, which maybe we should do. We say, hey, you know what? The death of that grandmother was actually attached to your buying a hamburger over at this place. You know, we don't do that kind of stuff. We don't have the people to do it, and sometimes we don't have the manpower to do it, but that's the way it is. So what are some other principles? Absence of disease does not imply that there is no disease. Of course there's disease, but this concept has always been argued about. I remember going and talking to legislators about the need to continue vaccinations, because in some places they say, well, why are we doing vaccinations? Because there's no measles around here, or there's no whatever the disease may be. And you have to explain, well, part of the reason there's no is because we did this public health measure. That's similar to where some of the stuff we're going to be facing now. There's not a ton of disease. Well, part of that is because we did social distancing, masking, hand hygiene, did all these factors, and it worked. Great job. But let's also use those principles to try to figure out going forward. Absence of disease does not imply that it's a time to abandon all infection control measures. We need to continue to assess the risk and benefit. I'm always up for the argument of how we're doing things, what's the expense to local business, what's the expense to our health. All those things got to be discussed, and that's fine. And try to use the best information to fashion a statement. And it's not cavalier. It's not saying, well, we'll never eliminate 100% of every disease. That's impossible. But we're trying to do the best for our families and our communities and our hospitals. So infection control measures aren't going to go away. They're going to still be important. The level of measures that we take will depend on, what's the susceptibility, the prevalence in our population. Do we have an effective vaccine? Do we have effective therapeutics? And what's our healthcare capacity? That will be an ongoing discussion and ongoing evaluation. And we will have a learning curve going forward. What we do now may be different than what we do in 6 months or a year, whatever that may be, taking all that information into account. Vaccine and therapeutics continue, and innovation. Look at the innovations that we're developing in terms of telehealth, remote monitoring, which is going to help, especially in a state like Kentucky, where a lot of our patients are coming from rural communities. They don't have the money for the gas to drive to Lexington. They might not have the money to go for the copay or whatever the part may be. So a lot of this stuff is going to be good for them and still improve their health. And public health measures continue. Masking and hand hygiene in school settings, office settings, probably will also depend on the prevalence. If we have 0 cases in our surrounding states and in Kentucky at some point, we'll back down on some of those measures. That makes common sense. We'll still need to be doing testing and surveillance, though, and still need to have the people to do the transmission disruption. One of the things that we have learned from all of this is that the benefits of community cooperation between public health, private and public partnerships, and hopefully that continues to go forward. We're not one hospital. We are a group of people working in different hospitals trying to make our community and our state a safer place and a better place. So with that, that's all I have to say. I'll leave it open. Do we have questions now, or what are we going to do? Mark, what do you got?
What was the reason for SARS-1 to disappear? Could that happen with COVID-19?
Nobody knows. First of all, 2 things. One is nobody knows why SARS-1 disappeared. It disappeared, I think, last case 2004. Even though there's a 70-some-odd% similarity to SARS, it is a different virus. So the original SARS transmissibility was less. The viral load, for example, at the beginning of illness with the original SARS was really peaked after about a week of illness, which made it easier to isolate asymptomatic patients. So you had, after symptoms, your viral load was kind of peaked at 7 to 10 days. This is totally different. It peaked at, it's peaking before. We have a peak at the beginning, and even before, say 5 days before, you still have a high viral load. Much more difficult to control, much more transmissible and contagious than the original SARS. So I don't think this will act the same as SARS. Nobody understands. Part of why SARS was able to go away was an aggressive public health measures to try to isolate patients. But this is going to be more difficult to isolate patients because you can be asymptomatic or pre-symptomatic and be spreading it to people around you.
The next question is, we have been given guidance to test patients for COVID-19 prior to surgeries and certain inpatient procedures wearing a surgical mask rather than the N95 we were using previously. Could you provide me the link for where this PPE guidance came from?
You want to talk about that more? I mean, the link, I can tell you, the link, you can go to cdc.gov, and that's the guidance for testing is basically using a surgical mask unless you're not suspected to generate an aerosol with that. But that's where some of that guidance comes from. But Mark, you can comment on that more.
Yeah, so as through this entire pandemic, we've had to look at our scarce resources and try to risk stratify and move forward. We know that the N95s are extremely scarce. When we look at our own supply of N95s, it's very misleading because a majority of those are actually KN95s, which are highly variable and don't function well. Some of them are KN95s with a one-way valve, which we don't want to see any of those used in the hospital. The one-way valve actually emits an aerosol and doesn't protect anyone else, just the person that's wearing it. The KN95s are of highly variable quality. Some of them are not NIOSH approved, and we therefore have a very limited supply of the N95s. So we have thought that a better strategy was to do universal testing, and that's become the standard actually. It's going to be the standard across the country actually. In a low prevalence situation like we have here, we think that that will dramatically reduce the risk of exposure. Of course, the one patient that we found here at Baptist Lexington that was actually infected before an elective surgical procedure was going to be operated on because of allergies and nasal polyps, which is going to be a very high-risk procedure. So the intervention there was to test her beforehand. The test was positive and the surgery was canceled. Now, one of the things that we've done, at least in the Baptist system, is to try to provide some N95s for reuse. So we're trying to do this in a safe way. I had produced a video that's up on our website and now on the Baptist website for how you safely, individually reuse an N95, how you dismount it appropriately and not contaminate it, store it in a paper bag appropriately, and then reuse it. If we use N95s for every surgical procedure, for everyone in the operating room, we'll have a few days worth, and then they'll all be gone, and we won't have any more. So we have to figure out a way to use those in an appropriate setting and to reduce our risk as much as possible. Also, in terms of the operating rooms, we want to, and as in any room in this situation, we want to minimize the number of people coming in and out of the room to conserve the PPE. And with regard to PPE, everyone's been talking about the N95s, but the thing that's in the shortest supply is actually the plastic gowns. So we've been trying to emphasize acquisition and use of cloth gowns, and also minimizing the use of the plastic gowns, clustering care. Don't be going in and out of the rooms repeatedly. I think one of the things that's been a little controversial, at first we were thinking that the nasopharyngeal swab was an aerosol generating procedure, and we were recommending full PPE for that, including the N95 mask. I think there's more of a consensus now that it's probably not an aerosol generating procedure. We probably don't have to have an N95 on for every time we do the nasopharyngeal swab, and that a face shield and surgical swab should be more than adequate in that situation. Over time, we may be moving to switching to do an oropharyngeal swab combined with a mid-nasal swab, which looks like it may be just as accurate as a nasopharyngeal swab.
A couple other things. One is there haven't been any literature discussing healthcare worker infection related to collection of nasopharyngeal swabs, whether it's using an N95 or a surgical mask. There's plenty of literature saying that using the mask itself, whether it's nasopharyngeal or N95, leads to a decrease in infection risk for healthcare workers. So in terms of nasopharyngeal swab, that hasn't really borne out. There were a couple other questions. One was, and this is, what do you do with patients that are on warfarin or some other medication in terms of their risk for bleeding? That isn't clear-cut in terms of what is done. What is done in some places is looking at D-dimer levels and using a protocol that if D-dimer levels reach a certain level, that they're started on anticoagulation, and it depends on the institution. Some institutions will do full anticoagulation. Some institutions will do a higher level of preventative therapy for DVTs. That isn't standardized, so that's something that institutionally you need to look at your own measures. Do you have a comment on that, Mark?
Well, no, I was going to change the subject a little bit.
Okay.
So there's another question about when should we be using tocilizumab? Do you want to address that, Dan?
Well,
I mean, part of this, and of course, part of the answer here is going to depend on the supply of tocilizumab. And actually, I think nationally we've been surprised that the supply chain has been fuller than we had thought of tocilizumab. We haven't had as much trouble ordering it as we thought we would have. It is expensive. It's $4,000 to $5,000 a dose, maybe more on the $5,000 side. And of course, it depends on the dose you use, and there's different dosing regimens. But it may, overall, if it's used at the right time and the right setting, it may substantially save money in terms of reducing number of hospital days, reducing time in the ICU, preventing ventilatory support, and so forth. But Dan, do you want to address when the sweet spot is starting?
Nobody knows the exact sweet part. Here's the way where it's boiling down to in different institutions. One is paying close attention to the oxygen saturation of that patient. So as the respiratory rate goes up, as their O2 requirements go up, say from 2 to 4 liters, they're also looking at doing multiple times during a day, which we don't always have available in your particular hospital, looking at CRPs. So if the CRP starts to increase by 25% within the day or within 2 days, and it's already elevated at a level that each institution kind of has set it at a certain level, 100, 200, whatever that level may be, that those are markers for a patient taking off more into an inflammatory state. They have not tended to use ferritin, which is more difficult in terms of correlating that with a taking off of the cytokine syndrome. And IL-6 levels in an academic institution have also been used. But again, for us in a community hospital, we don't have IL-6 levels available on a regular basis. But IL-6 levels that start to increase, depends on which study you read, are also used as markers. So I would say the most important markers that we tend to look at now are CRPs, O2 saturation in terms of what they're looking at, and then other aspects that tend to correlate with the cytokine storm, persistent fever. Those are measures. Now, every institution, including local hospitals here, has kind of come up with a loose guideline. I think the time to use it is before ARDS. If you develop ARDS, I mean, it's still being used, but let's use it prior to the cytokine storm basically getting out of control, where you have a positive feedback mechanism of those cytokines, and it's more difficult to control. You have already the more damage that patient's transitioning to needing the ventilator and having ventilator-associated lung injury. So the point will probably be before that, based on clinical parameters, CRPs, IL-6 levels.
And probably on degree of respiratory failure, too. One of the next questions was, when should we be ordering antibody levels and on the outpatients? So that's a little bit of a tricky question. So there's several issues there. One is that we, at this point, haven't encouraged use of antibody levels. It may be useful from an epidemiologic standpoint, but just because you have a positive antibody, first off, doesn't mean that you're not infectious, because you can have a positive PCR at the same time. And secondly, it doesn't necessarily mean that you're immune. It looks like, at least from some information we got in our statewide ID talk with Chip Schooley about a week and a half or 2 weeks ago, he's from UCSF and a researcher there in infectious disease. He indicated to us that when they were checking antibody levels, that only the minority of younger patients were developing neutralizing antibodies at that point. So that was early information. That's not conclusive. He just said that he was a little concerned about that. So we don't really know at this point what a positive antibody means and whether that means you're immune. There probably will be some development of immunity, but we don't know how long. We also don't know how long lasting that is and whether someone's going to be partially immune now and then more susceptible later. But Dan can address this.
Okay, first of all, I don't think there's a large role right now for antibody testing. I mean, especially you talk about the Celix test that just came out. Now, that got a lot of publicity. But in our community right now, with the prevalence being probably less than 4%, and that test having a relatively low sensitivity, you can have, it's a 50-50 toss-up in terms of having whether that's a false positive or a true positive. So that test really, I don't think, operates very well in our setting. So I don't think antibody tests there. I think there's going to be a danger to assume that you're going to be immune. We don't even know how long immunity may last. So an IgG level right now is not, it tells you that you were potentially exposed if you're talking about a good test, like say the Abbott test or even the Roche test. Those ELISA tests do have a very high sensitivity, so that's more beneficial to using it, and they don't have a lot of cross-reaction in terms of their specificity, so they don't have a lot of cross-reaction with other coronaviruses, which has also been a problem with these early antibody tests. So as we get really good antibody tests, they're going to be helpful for understanding the prevalence in the community. Maybe I was exposed, but using that message to say I'm now immune is a different issue. This whole neutralizing antibody, there's a lot of caveats to all this data. The older patients tend to develop antibody titers. Younger patients don't tend to develop antibody titers as much. So the sicker you are, the more likely you are to have an antibody titer. The less sick you are, the less likely you are to have an antibody titer, especially neutralizing antibodies. So there's a lot of measures to that. We don't understand until we have better data, maybe from animal models, what that'll mean. They never were able to do a lot of those studies, especially with humans, with SARS and MERS, because we don't have enough of those cases. MERS is still existing in a limited fashion in the world. SARS completely disappeared, so we don't have a lot of corollaries to use with those previous outbreaks. But I don't think there's a great benefit other than knowing you might have been exposed if you use a good test. How to do it past that is unknown.
The next question was regarding which test do we use and in what setting. We're using, at least that, well, first off, that's going to depend on which hospital you're in. So a number of the hospitals are switching over to using Lexar for pre-op testing. That's a toxicology company here in Lexington that has the capability currently of doing 400 tests a day, and I think is going to ramp up to doing many more than that. At this point, Lexington and Corbin and Richmond and perhaps Paducah are going to be using Lexar for pre-op testing. The turnaround there is, well, anywhere from 24 to 48 hours. We're trying to get the pre-op testing for all elective surgery and certain elective procedures done. If you have an operative emergency, or if it's an endoscopic emergency, or TEE that's in the hospital, that has to be done the next day, then we're suggesting that rapid testing in your own hospital be performed. That's going to depend on which hospital you're in. So here in Lexington, we now have the availability to do 48 rapid Abbott tests a week, and that will turn around in less than an hour. We will have the Cepheid machine up running later this week, and we'll have 12 tests a day to run rapidly. So if there's a surgical emergency or another procedure, a TEE, upper endoscopy, if it's a STEMI, a stroke, a DVT or PTE, those kind of things that needs intervention, those kind of things we're going to do with the rapid tests that are available actually in the hospital.
There was a question on the inflammatory syndrome that's being discussed in New York City and LA County. Data are still not well described. So telling you what other risk factors were involved with those patients, I can't tell you that right now. I can tell you that it's been discussed that most of the children that get hospitalized with COVID tend to have comorbidities like asthma. Asthma is a common feature. And there was an interesting discussion about, while children overall seem to have a mild disease, if a child is markedly obese, it actually kind of makes that child look more like an adult in terms of their outcomes. So some of the comorbidities are still important. I would say that most of them that are ill tend to have those comorbidities, and they'd be asthma, diabetes, obesity as side issues that makes them more predisposed to getting sick. The whole issue with Kawasaki's is still under evaluation in terms of other risk factors.
I don't think there are a lot more questions right now. Dan, do you want to check and see if there's any more that have popped up? I do want to say that I think in the healthcare community, we all want to really promote masking in enclosed environments. We know that masking is not important outside. If you're 6 or 10 feet or more away from someone, that's not going to be a mode of transmission. If you're in an enclosed space, in a shopping area, in a grocery store, everyone needs to have a mask on, and we really need to promote this. I was very disturbed a couple weekends ago when I went into some hardware stores, and about 60% of the patrons came in and were masked, but almost none of the employees were. So, of course, there's been guidance by the governor that everyone needs to be masked in those types of settings, and I think as healthcare workers, we need to really promote that. I went up and actually talked to the managers of those stores and suggested that they really strongly consider that. And I think we need to emphasize that I'm wearing this mask to protect you. It's not the reverse. This mask doesn't protect me as much as it protects someone else.
One other question was regarding, again, antibody testing. I don't know, depending upon where your office is at, what access you will have to antibody tests. I can tell you there's 12 FDA-approved antibody tests, but you don't have access to all of them. I think the Celex would not be a test that I would order at all. I don't think it has any value. Whether or not the Roche and Abbott tests are going to be available, at some point they will. How we use them, as I said before, I don't think we have a good idea yet in terms of how to correlate that with neutralizing antibodies and such. You're going to look at some of the publicity, like today on the news, they talked about UK doing a study looking at some of their antibody, doing serology. There's probably some benefit within the health systems to do serosurveys using a good test, just to get an idea of the prevalence within your workforce. But we can't say that is going to be a measure used for immunity or immune passports or something along those lines. At some point, we will have more information where we do match IgG titers, for example, with a neutralizing assay or an animal model that says you're protected at this level, but we don't have any of that data. And we also will have to wait to see how long immunity would last, because we know from other coronaviruses that immunity from the other coronaviruses is not lifelong. So that will not be a measure to bank on going forward. We still need to work on therapeutics like vaccines and medications to treat this. Thank you for your time. I hope you got something out of this. We'll try to resume this maybe in a month or so, unless something else significant happens. Thank you.